Hey guys, Dr. Andreo Spina here for another installment of the Control Yourself podcast. We're going to do something a little different here. I've brought on one of our lead instructors, Alex Nichols. Hello, Alex. How are you?
What's up, man? How you doing?
I'm good. And what we figure we do is because a lot of these times when we're doing conversations, when I'm talking to practitioners or people who are familiar with the system that we use. Of course, we try to give a bunch of information that would be helpful for people outside of the system as well, but oftentimes it falls back into, you should really, get an FRA done and look at what your shoulder is really capable of, or we should look at that hip in more detail. So we throw out a whole bunch of terminology. We should do an FRA to assess it. We should do an FRC to increase the capacities and whatever. We should do FR to treat any architectural dysfunction, et cetera, et cetera. So there's a whole bunch of terms. So I figured I'd bring a person who specializes in these terms, as you've been traveling around the world teaching the system. And I figure we can, talk back and forth and answer some questions that possibly a lot of people might have. Um, of course, we're on Instagram time and social media time. So it's very easy for a
Mhm.
message or a concept to get um, exaggerated or misunderstood or taken in the wrong context, etc. So I hope that was a good introduction as to what we're planning on doing. And with all that, I have not even let Alex speak. So, Alex, what's going on, my friend?
Yeah, we can jump right into if you want to go over the FRA stuff, the FR stuff. I think that it's a good opportunity to define what an assessment is and why the FRA, for example, is the FRA, like if we want to start with the assessment, or
Mm,
what manual therapy is, or how it's been understood and conceptualized up until FRS has kind of tried to revise some of those blind spots and account for them. But I
mhm,
think that's really the starting point, because from there, everything that happens in either of those courses makes more sense. So maybe it's best to start with the assessment. What does it mean to have an assessment, right?
mm,
What are we looking for? These are the kinds of questions that I think that you and Dr. Chivers, Dr. Thratsiotis, all of the other instructors have done a really good job of helping providers think about more. Are we
mhm,
looking for pain? Are we looking for adhesions? If we were looking for that, what is that? Is it
mm.
definable in the literature, right? Or
Yeah, I
not,
mean, if you
right?
want to start an assessment, I mean, yeah, the FRA is our start point. And I mean, every practitioner has a start point where there's a human system in front of them, and it's their task to decide, what do I do with this system? Like, what are the things that would best benefit this person in the way that they need be benefited?
Hmm.
And I think for the most part, or at least what I noticed when I was studying, is that the answers to those questions always seem to be the composite of a group of articulations and a group of tissues and seeing what they're capable of when tasked to do a movement challenge. If
Hmm.
that makes sense. So it's like
Hmm.
if someone comes in, you go, okay, I'm going to start my assessment. So how do I start my assessment? Well, let's say you're going to start with a movement assessment. So you get the person to squat with their arms over their head, you know, and
Hmm.
and you're observing and you're trying to find things in the system, or you're trying to find findings that give you actionable information.
Hmm.
But the problem with a lot of assessments, especially movement assessment, sports assessment, is the information that you garner may tell you that there's something wrong with the way the system is emerging a movement, but
Hmm.
it does very little to specify what tissue or what structure or group of structures are
Hmm.
hindering the type of movements you want to see. So when someone squats, their knee might come in. So automatically you say, oh, you score a two or whatever. I'm not
Right.
talking about any particular system, but let's say it's a scoring system, or you
Hmm.
you get an 8 out of 10 because your knee comes in.
Hmm.
And then what usually happens is that in order to fix the problem, instead of saying, well, why does the knee come in?
Hmm.
when those questions are thought of, it might be because someone says, well, when you're squatting down, the adductor longus at the basement of a squat is in a really elongated position. So if that muscle is tight, then when you squat down, as that muscle lengthens, it's going to pull that knee in.
Mhm.
First off, the problem with that is that when you tell me that a muscle is tight, we've
Mhm.
talked about this before, it might be enough for the general population, but for someone like me or someone like you who actually then is tasked to develop a plan to alter the physiology in such a way that it is untight, it
Mhm.
requires more information. Like, what do you mean by tight? Is it always tight? Is it tight because there's, it's riddled with scarring or adhesion built up over many years?
Mhm.
Is it tight because there's a neurological influence, et cetera, et cetera? And that is granted that that is the actual problem. The problem, though, from an observation standpoint, when doing an assessment, is you don't really know that, right? Just because that leg's coming in, you can't say, well, what's the origin and insertion of a particular muscle, and then draw a line between them and shorten the muscle and say, oh, you see, that's why it doesn't function. Because
Mhm.
that's not really how muscles function, and that's not how the system functions.
Mhm.
There's a variety of tissues that may be involved in something like my knee is coming in. So what happens is the knee comes in, and then what ends up happening is the programming is then put in place to try to reverse the finding that you saw during the assessment. So
Mhm.
now training becomes keep knee out, keep knee out. But there's several problems with that because a question can be asked at the outset, why is the knee coming in?
Mhm.
As you know, a squat is a composite or a combination of articular and tissue function that
Mhm.
is emerging a particular movement pattern that is dictated by the word squat. So you say squat, I do what my brain thinks a squat is. So there's boundary conditions in
Mhm.
in that squat.
Mhm.
So like when you're squatting, it's not enough to say there's something wrong with it. What you have to do is you have to take the components of the things that give you the squat, the tissues, the articulations, etc., and you have to individually assess them to understand what they're capable of. And I often say, in the sum of the parts, there's only the parts, right? We when we're trying to assess a system, we don't really have access to the system itself. If you say while you're squatting, keep that knee out, well, now you've moved into the realm of practice, audible
Mhm.
cues that tell you to activate your nervous system in a particular way in order to
Right.
keep that knee out. But again,
Right.
if there's biological reasons why that knee is coming in, then you cannot practice yourself out of biological dysfunction. So I guess long story short is
Yeah.
with regards to movement assessment, it's good information to indicate there might be a problem, but
Sure.
it's not actionable information such that the answer leads us to a set of actions or inputs that might reverse that problem. Does that make sense?
It's not a complete finding or it's not a complete picture, right? It's
Exactly.
the
It's akin to seeing, a a coach, let's say, for example, saying, your stride is this particular way, it should be this way. So it's an
Mhm.
observation in time
Mhm.
as to how the system is emerging this desired movement, but it is not an analysis
Mhm.
of how the system is producing the movement.
Right. And I think I mean, that's something, as you were describing that, I was thinking a lot to back when I used to kind of work as an in-house trainer for various physical therapy clinics. And at the time, I was not trained in FR, right? I hadn't
Mhm.
become a manual therapist yet. So I was just a strength coach. And a lot of the findings that I had questions on were some of the things that you're discussing here. And really, it just sounds, again, it's a lens problem where the words like activation, this is weak, like you said, this is tight, which is a really good way to communicate with, your average person who maybe doesn't know a lot about anatomy and physiology, because it's a very, it's an oversimplification. And
Mhm.
so it's much easier for us to digest and go, okay, it's just tight. It's a very linear way to communicate. But the
Mhm.
reality is, as you and I know, is there's a lot more nuance to that problem
Mhm.
because even if you were to start to dissect the words activation. What does that mean? Is that the same as motor unit activation? Right?
Hmm.
Those are different things compared to how we describe and teach what an activation exercise is compared to, let's say, motor unit activation.
Hmm.
Or when we're just looking for pain, this
Hmm.
hurts here. A lot of clients will come in, they'll point, when I push here, it hurts. When I do this, it hurts, which is still good information. But again, it's not a complete picture. So what I'm hearing you say, just to kind of relate it back in sort of layman's terms, is it's really easy to try to problem solve movement problems with more movement solutions, but
Hmm.
it's not going to specifically change a system that's complex, nonlinear, adaptive, and of which the parts we haven't even deconstructed and started to assess. And I think maybe this is a good segue into why FRS does that, right? Why we all do this is because one of the big blind spots we feel is that these tissues, these joint and connective tissues, are not appreciated for the level with which they can be trained and assessed.
Hmm.
And I think
I see what
that's
you're saying. It's a very good point in that,
yeah,
it's like the hammer nail thing. It's like if you don't have the knowledge as to how to generate inputs to fix the specifics of this problem, you fall back on the generalizations of the problem. And then you generally try to just make whatever you're finding better. You're right. It's the same thing with regards to manual therapy. When I'm teaching a manual therapist, that
yeah.
just because something hurts to touch it, it doesn't mean that it's a finding pertinent to the person in front of you.
Hmm.
It doesn't mean that that particular spot on the body needs to have something done to it to unpainful the palpation.
Right.
Because as you
Right.
know, there's a variety of areas in the body which are just subject to pain on palpation. No
Yeah.
matter what you do. We've talked about, that
They don't feel
imaginary
good.
spot here that they call the levator scapula.
Right.
Or when someone's getting a massage, right in their
On their
flank here,
kidneys.
on their kidneys, right? And they go, oh, your QL is tight. Or when you're
Right.
driving an elbow into the butt and you're hitting that, the sciatic nerve as it goes under or through the piriformis and you're
Hmm.
getting that, oh my God, that hurts. And go, oh, well,
Hmm.
that's the thing that needs to be rubbed and or acupunctured and or massaged and or manipulated. And the fact that there's so many of these and ors speaks to that problem as well. I
Hmm.
often will talk to practitioners and, if they're discussing a case, there's a case of chronic low back pain or whatever, and someone says, well, did you try ultrasound?
Right.
Or did you try acupuncture? Or did you
Right.
try spinal manipulative therapy? Which is another way of saying, I don't really understand to a histological, physiological basis what these inputs are supposed to achieve.
Right.
Therefore, I'm unable to make a conceptual framework as to when these individual inputs would be utilized or useful for the
Hmm.
problem in front of me.
Hmm.
If that makes sense. And that goes back to what you said before. It's if you're a massage therapist and you feel, your job is to massage, then when
Right.
someone comes in and they say they have a pain finding, then automatically you massage. Now what you were saying is that, and you're probably getting this from when you teach the courses, because when you teach the courses, there's a lot of aha moments where people, it's not like they don't have the necessary knowledge to do these things, is that they never
Hmm.
thought to organize in a systematic way the
Hmm.
approach to tackle these individual problems one by
Hmm.
one, before trying to just alter the composite or alter the movement in whatever way you feel is beneficial.
Yeah. Yeah. It's just to your pain point as well. It's not to say pain management is obviously very important, very valuable. I tell clients all the time, the best thing that you can do to manage your pain is whatever the thing is that helps you manage your pain. And I
Mhm.
don't say that facetiously. I tell them, I do whatever you want. Obviously, we can go through much more specific strategies that also include remodeling that tissue.
Mhm.
But treating pain and managing pain is very different from making long-term changes in tissue. Um,
I think it's worth pointing out that even I know you just said it off the cuff, but the concept of treating pain is something that I also question. Managing pain,
Totally. Yeah.
managing pain that is arising within a system
Yeah.
is something that we can indirectly influence by our ability to, in time, alter biology, alter
Mhm.
anatomy, such
Mhm.
to reverse either the reasons for the pain or
Mhm.
to
Mhm.
reverse the things that occurred to the tissue as a result of the pain.
Mhm.
Oftentimes
Mhm.
with clients, I mean, how did this happen? Well, you know what? It really does. I don't know sometimes. I don't know
Yeah.
how it happened. Did the pain, do you have pain because of some psychosocial factor or some other reason?
Yeah.
Are your thresholds lower because you didn't sleep well or whatever it is? Pain itself
Exactly.
is a very nuanced problem.
Yes.
Nociception stemming from aberrant anatomy
Mhm.
is also nuanced, but it's
Mhm.
nuanced in a way that we can directly affect
Mhm.
as manual therapists, as trainers. So I
Mhm.
think that it is important to sort of cut in to say that
No,
we might
no.
manage pain, but it's
Mhm.
worth explaining that, we're managing it by making the system do what it's supposed to do and by
Mhm.
increasing capacities where needed. You're an athlete. You can't just have a regular functioning body as an athlete. You need to have
Mhm.
need to have capacities heightened in certain areas in order to allow you to do what you do.
Hmm. I
So,
want to I want to unpack that more from a manual therapy perspective, especially for people that are unfamiliar, because we obviously work with a lot of folks that are manual therapists, and then also a lot that are, let's say, just strength coaches. But to the assessment point, just to wrap that, I often get I just had this the other day. I mean, I have this conversation, I don't know how many times a week. It hurts here,
mhm,
so can you assess here, my knee, let's say.
mhm,
And I'm always happy to do that,
mhm,
obviously, but I always lead that into the conversation of, I don't know that you have knee pain because you don't have a localized knee issue in a
mhm,
specific tissue. And I don't know that you have knee pain because you don't also have a hip problem, right?
mhm,
And again, I can't say for sure, unless obviously they come in and, hey, I tore my ACL, that's pretty clear there. But it gets us into this language problem again that I think manual therapy, because I was going to ask you, what are some of the limitations of manual therapy and what is manual therapy? But before I get to that, like, what's a knee, right? Somebody says, I have a knee problem.
mhm,
As I quote you all the time, and I steal this every day, I tell clients, I haven't met your knee yet,
mhm,
right?
mhm,
But what that leads into is what's a knee?
mhm.
We have two bones, three bones technically, right? We
Mhm.
have a joint
Or
space,
if you include the patella, you have
or if
that.
you include the
Yeah.
patella. You have all these connective tissue structures. You have the popliteus, you have the coronary ligaments, the MCL, the LCL, the PCL, the list goes on. So when
Mhm,
somebody says, I have a knee problem, they might be right, but the definition of a problem has to be understood in this anatomy and physiology, or from the lens of anatomy and physiology, which is really the lens of myofascial force transmission,
mhm.
because
Yeah.
that's where I think, FR and manual therapy really helps to highlight a lot of the limitations. And again, not to say that they're not valuable, but traditional manual therapy, as it's understood, has its place for sure. But there's really no mechanical loading in these soft tissue practices. And that really gets us into, what is manual therapy and what
Mhm.
is mechanical loading? Because I think again, well, if I take a ball and I smash my quad,
Yeah.
you know, isn't that gonna solve the problem? Or if I take a Theragun or if I scrape it. But again, you didn't get to we didn't decide what the rules were, right? This is just the evidence-based medicine aspect of FR when somebody takes an FR course and understands, like I went to massage school.
Mhm,
So when we learned palpation, I mean, it's very, very, here's the delt.
mhm, mhm. Yeah.
Okay. I mean, but the reality is for a lot of people, right? That's where the concept of the delt ends, right? But the reality is, anybody who's, as you've mentioned, and all the instructors have talked about this. If you've done dissections, you've looked at cadaver labs, surgeries, etc. By the way, I'll also say if you've undergone any surgery, you really start to appreciate, especially if you do rehab using the FRS model, you really start to appreciate the nuances of tissue. But to
Mhm.
bring that back to the delt, I mean, the delt isn't just, it's not just this. And that's not palpation. That's just poking, the anterior side of my shoulder.
Mhm.
Because again, it's very easy to oversimplify this kind of superficial look at anatomy. Well, if I look at the shoulder, it's just here. But
Mhm.
you really have to peel back the layers to understand what's happening at the deepest levels and work your way up.
You know, I was thinking there's a lot of points there, but I wanted to dive back a little bit to make sure people aren't confused. Because we're talking about oversimplification and overcomplication, and I feel like people do both.
Mm,
So, for example, what we were referring to earlier, when you say you have a knee problem, we're not saying, as many people do, that, the knee problem is stemming from, and then make your list of anatomy in between the knee and wherever you want to bring the problem to that allows you to do your special technique to fix the
mhm,
knee. Um,
mhm,
People often insert the word kinetic chain here. Like an
mm,
example I always use is that, you come in with a right shoulder problem, and arguably, I can always correlate or almost always correlate a right anterior shoulder problem to a left big toe problem. You want to hear
right,
how? Well, it's easy
right.
because your latissimus dorsi, which inserts into the groove on the anterior aspect of the humerus,
Mhm,
goes posteriorly around. That's why it's an internal rotator. Now, the latissimus dorsi continues across the pelvis to the contralateral gluteus maximus, especially between L4 and S2, as per the studies of Leeming, et cetera, et cetera. Now, when you go to that gluteus maximus, of course, the maximus fascia contributes fascia to the overall combination of fascias coming from the TFL and all the glutes to make the iliotibial band. The
mhm,
iliotibial band, of course, goes to insert onto the fibular head, but also continues anteriorly with the tibialis anterior. So now you have from the fibular head, it continues down along the fibularis. From tibialis anterior, it continues down along that, which both meet at the bottom of the medial cuneiform of the foot of the first ray of the big toe. Ergo,
yeah,
your right shoulder problem is because your left big toe doesn't work. Okay, so I
right.
don't I don't want to get clumped into that problem because that's not what you're saying. Now, the
But
reason
that's also still true, right?
yeah, all of what I said is true,
Right, right,
but the ability for me to connect those dots, the ability
right,
for anybody to connect those dots is
right.
impossible. There's so much anatomy and so much, you know, nuances of function of that anatomy between that shoulder and that toe that it would be
Mhm,
impossible for me to say that. However,
mhm,
what we also say is that if you do have a right shoulder problem,
mhm,
and you do have a left big toe problem, which is going to bring me back to my FRA,
mhm.
I'm not just going to treat your shoulder problem and let you go
Right,
with that shitty big toe because
right.
I don't know. I don't know whether or not they're related. And to a certain extent, it doesn't matter to me because for the system to emerge proper movements when called upon, it's either
Mhm,
the components function properly and have
mhm,
the capacities to do what you're asking of them, or they don't,
mhm,
right?
mhm.
So yeah, if someone has you were talking about a knee problem. If someone has a knee problem, they also have a big toe problem.
Right,
The FRA, the functional range assessment, will pick up on both of those problems.
correct.
And then the treatment, whatever that means, the management will address the system as a whole. Now,
Mhm,
that's where we get into this overcomplication thing about the kinetic chain and all this goes to here.
mhm,
But people often also oversimplify the local problem because of a
mhm,
lack of palpatory ability to
mhm.
distinguish
Yeah,
where the problem is. And now
yeah,
you said you're going to massage school, and I of course went to chiropractic school. And what did
yeah.
we learn in those? We learned about orthopedic tests,
Mhm,
imaging, both of which only really tell us about macro tissue injury. right?
Yes.
What we deal with on a regular basis is micro tissue injury, but there's no orthopedic tests for that. So when you have that knee problem, the difference between knowing what's going on and not is your ability to use your fingers and your hands to actually isolate tissue and to
Mhm.
determine if there's pathology in that tissue, which is 100% dependent on your ability to palpate accurately, which
Which
brings me,
is a skill.
which is a skill. It's a trainable skill, which actually brings us back to the original reason why the
Mhm.
functional range systems began, because I began with
Mhm.
functional palpation, which was
Mhm.
a response to me noticing that my education and the education of most other manual therapists that I talked about do not distinguish, to the extent that it is possible, the ability to palpate tissue.
Mhm.
Now, we say that, and now there's another swing of or side of people who are going to hear what I just said there, and they're going to say, well, you overestimate your ability to palpate. We really don't, because there's a lot of non-palpable structures. The lateral pterygoid, for example, is a structure that a lot of
Yeah.
people think they're palpable. It's just a non-palpable. There are non-palpable structures.
Mhm.
Um, but if you are using a systematic approach to breaking down the body that uses reference structures, that
Mhm.
finds easily palpated structures, and then works from that point to another point to another point in order to try to distinguish what it is you're actually touching and whether or
Mhm.
not the palpation of that thing you're touching is painful, which is not
Mhm.
really a finding, or recreating the problem, which
Mhm.
is a very important finding. So now you
Right.
combine the specificity of isolating the problem
Mhm.
with the concept you said before about taking a broad systematic approach to the management of that problem.
Mhm.
Now you have a scenario where you're mixing very specific inputs for the purpose of propagating healing in the tissue that is affected, and you're
Mhm.
also using uh, a variety of joint inputs to try to improve the function of the joints, which allow for the movements
Mhm.
or don't allow for the movements, which is likely the cause for the originating anatomical problem as it is.
Mhm.
So people overcomplicate and undercomplicate.
Yeah, I think it's a fair point because I've heard that as well, like a, whatever, passing criticism of the system, right? You guys make things too complicated. But we can't make up that a shoulder has multiple tissues involved or a knee has multiple tissues involved. They have different depths, different
Mhm,
directions, different tolerance to length,
mhm,
different costs associated with moving to length. These things are not, they're not made up. They're part of a person's individual history,
yeah.
which is why your left shoulder and my left shoulder aren't the same shoulder. We've done different things, there's different histories, which is why taking an internal perspective when you meet a client and assessing, how much does your shoulder move? And then maybe this merits we need to go and dive into some of these tissues and look at where we might have some findings, which
Mhm,
again, to bring back the manual therapy discussion, we're really sort of disconnected from, I suppose in one way, we're actually very connected to how much we use our hands, right? From an evolutionary perspective. But the ability to mechanosense is really underappreciated as a skill, a teachable skill that requires your finger pads, which we talk about at length in courses of how sensitive those are, how many nerve endings there are in the finger pads, how much cortical density is dedicated to trying to feel and basically dedicated to the hands for feedback. And what's really cool about that concept, mechanosensing, is that that's really from a micro scale, that's what cells do. So in a
mhm,
lot of ways, we're just, if we're a bunch of these small components like cells, like fibroblasts that sense for mechanical forces at a macro scale, that's always what I think about when I'm doing FR. You're just a bigger version of these small cells. And so that, like, even if people want to debate that, you're feeling for more than you think, um, you interact with,
we're
yeah,
feeling less than you think.
less
That's
than,
what
yeah, 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 yeah,
that's what people don't seem to, but continue.
yeah. that so even if you want to debate that, I mean, so this gets us back to like what the role of mechanical forces is from an
Mhm.
evolutionary standpoint, but also just from a musculoskeletal standpoint. A lot of what we do is force based. We're just doing it on these macro scales, right? So we're not attuned to how small and how specific you can actually be with your hands.
Something came up as you were talking, and I think a lot of the problem is it stems from everything stems from social media, doesn't it? It stems from our ability to communicate with each other because now, of
Right.
course, everyone's an expert, everyone did their own research, you know, and when we put stuff out, when I put stuff out, it's hard to distinguish where it goes because when I'm speaking, usually I'm speaking to the practitioner, the medical doctors, the manual medical
Yeah.
practitioners, the strength and conditioning coaches. But it's consumed, of course,
Hmm.
by lay people, by the masses. And the problem with that is that they're right. You might not need to know to that specific level what's the
Hmm.
problem. But when there is a problem,
Hmm.
that's why therapists exists, is because this general overarching, well, I'm doing a good exercise program, I should be fine until I'm not.
Hmm.
That's good for the general population, but then when there's a problem, it's
Hmm.
not enough for one of us to
Right.
say, well, your knee hurts, let's put some ultrasound, and it's just like you're a jujitsu instructor.
Hmm.
And if you were training someone who's 45 years old, three kids, busy
Right.
job, just comes to be, wants to exercise, wants to learn to defend, there's a difference between the specificity of teaching for that person versus the highly competitive black belt or the person who
Totally.
wants to teach others.
Hmm.
There's levels, of course, to everything. There's
Hmm.
levels to everything. I can manage my car, sure.
Hmm.
But as soon as that clicking starts in the car, I have no idea
Right.
what component
Right.
of that. And the fact that I drove the car nicely this whole time, I
Right.
used my system to extra. It's irrelevant now because now a belt is broken, or I don't even have the vocabulary to make things up. The piston isn't
Yeah.
firing the
Yeah. Yeah.
oil into, like, I don't know, but we
Yeah.
need to know because it's our job. Now, you said with regards to manual therapy, we can extend that. With regards to manual therapy and training, all we're doing is managing force input because, as you said, that's how the body understands its environment. The cells speak to each other via the language of force. That's how they communicate information.
Hmm.
When forces are applied over time, you will get a change in the anatomical structure such that it will allow that force to occur with a lesser usage of energy because that's what the body does. So technically, everything we do, from
Hmm.
FRA, functional range assessment, to FR, functional range release, to
Hmm.
FRC, functional range conditioning, to Kinstretch, to the strength model, is harnessing the power of force, but
Hmm.
specifying where those forces go.
Yep.
Opposed to the general system of exercise that most people pull exercises from, which
Hmm.
does the opposite. It just takes this general, what's good for my back? Well, what's
Yep.
good for my back is it's can be answered very generally,
Hmm.
move around a lot, good
Hmm.
diet, you know, whatever that. But to us, we need more information in order to
Hmm.
understand what it is about your back that's going wrong. So I think
Hmm.
that's just a miscommunication problem.
Hmm.
With
Hmm.
regards to therapists, I think that there's this, you talked about palpation. Well, what are you feeling for? Well, mechanosense, the only thing I'm really feeling for
Hmm.
is forces.
Hmm.
Almost every receptor in your body functions on mechanical force. Even your
Hmm.
eyes. When a light molecule lands on an opsin protein on the retina, the opsin protein accepts that light molecule and then alters its form. And that change in shape, which is a force-based change, is what
Hmm.
propagates that information to the central nervous system. Well,
Hmm.
technically, it's already on the optic nerve, but through the central nervous system to the lobe that needs to be in order to represent or understand what that light is showing you. But
Hmm.
almost every one of our senses are mechanical. You know,
Hmm.
if that makes sense. So I'm palpating someone and I'm taking a tissue to length. There's a normal feeling when a tissue goes from short to long. And the
Hmm.
normal feeling is there's very little internal tension to be felt until you
Hmm.
start to get to the last third. And then
Hmm.
you'll have this kind of nice gradual uptick of tension. And
Hmm.
we even know from studies that take tissue samples and they pull them at length and then they measure the stress strain.
Hmm.
We know that for every amount of pull you put into a tissue, the amount of stress and strain is going to go up by one. So it's going to go one strain, one stress, one strain, one stress. In other words, all connective tissues have a one-to-one ratio, such that when they're being brought to length, that
Hmm.
gradual rise of tension, we often talk about it, it's like an escalator. It's
Yep.
gradual rise, getting higher and higher and higher until the end range where it peaks, and then you have that plateau.
Hmm.
That's normal.
Hmm.
All tissues respond the same. So now, with regards to mechanically sensing or what are we teaching when we're teaching someone how to palpate? Of course, we're talking about isolate the structure, what structure you want, exactly, what depth, et cetera, et cetera. But once you're there,
Hmm.
it's a matter of trying to understand those stress strain curves of each tissue.
Yep.
Do I find nice escalator increases in tension coming
Hmm.
back at my fingers as I'm moving the tissue to length?
Hmm.
Or do we feel elevators where it starts off and then boom,
Yep.
it just
Yep.
jumps right up and now tension, tension. So now before the end range, I get this rapid increase in tension. Now,
Hmm.
that doesn't necessarily mean the range of motion will be limited. If there's
Correct.
tension within this line of the bicep, the
Right.
other areas will allow that range of motion to be acquired. But if I
Hmm.
start to feel aberrant tension within a normal range of motion before these
Hmm.
end ranges or tensions found, there's there's something there. Let's just general. There's something there
Right.
with proper force inputs to counter it over time will change the dynamic of that tissue such that it will return back to the normal one-to-one ratio.
Hmm. Hmm.
That's as simple
Yeah.
as I can explain the concept of trying to palpate and then trying to analyze if there's aberrant tissue. Now, what are these changes? This is another argument. But we know from injury that when you have injury, when you have a reduced amount of ability to achieve length over time, that the organization of the connective tissue becomes more haphazard.
Hmm.
And we know by palpating people post injury that that feeling
Yeah.
oftentimes feels exactly like the feeling that I'm trying to teach. So
Yeah.
we can make a conclusion based on first principles that that tension
Hmm.
is probably, and I'm going to put a pin in this, is probably due to an abnormal architecture in the connective tissue that, if forces are applied subsequently in the proper ways, can reverse that problem. Now,
Otherwise known as fibrosis.
otherwise known as fibrosis.
Yeah.
Now, is that an adhesion? No. Am I feeling for adhesions? No. Am I feeling for scar tissue? No. I just finished saying that I have no scar tissue receptors on the palm, the pads of my fingers. I can't, oh, there's a piece of adhesion. I can't, a piece of adhesion is arguably a piece of collagen that's, nanometers in diameter. I can't feel those things, but I can feel forces.
Hmm.
And I can improve my hand's ability to feel force,
Hmm.
which your haptic ability is a trainable quality. It is
Yep.
100% a fact that if you try to get better at palpating and you apply the exercises, you will get better at palpating,
Hmm.
says neurology. I'm going to get back though, because there are nuances. That feeling that you felt isn't necessary, with regards to length. It could also be a neurological problem,
Yep.
right? Whereby it's not that there's aberrant tissue quality, but it could be that the nervous system is just overexcited and is putting too much motor input to that tissue. But
Hmm.
those things are going to come across very different to a trained practitioner. So
Right.
there's oftentimes there's a complete reduction in range of motion, but it's reduced in a way that as I move, the entire muscle is very spastic or reactive. The entire muscle is
Hmm.
blocking that end range of motion, right?
Hmm.
And that's a completely different thing that we'll talk in functional range release about. Is it mechanical tension stemming
Hmm.
from fibrosis or assumed fibrosis, or is it neurological tightness stemming from abnormal neurological discharge, which can happen if pain is continued for long periods of time? It can happen with acute injury. There's a difference between spasm versus tightness that
Yep.
needs to be understood. And really, when we're talking about functional range release and the course and functional palpation and that's really what we're getting at. How do you make these assessment decisions from a manual standpoint? And then how do you apply forces in order to counter that problem over time? Over
Hmm.
time, Alex, as
Hmm.
you know, that's
Hmm.
another key issue that I feel when you're a pain focused person comes in, you're going to rub that person until they feel the pain is better,
Yep.
which is otherwise known as touch induced analgesia,
Right.
which means that, if you hurt your elbow, you can do this, you can do this, you can do this, you can do anything, and it's going to feel better. But again,
Right.
you and I do not have the luxury to live in it for this particular in this particular thing. We don't have the luxury to live in a generality in
Hmm.
general terms,
Hmm.
right? My
Hmm.
hamstrings are tight. What should you do? Oh, jump on a foam roller. Whoa, whoa, there's a lot between
Yeah.
the
Yeah.
feeling of tightness and the automatic assumption that if you smash an object into that tissue, that somehow it's going to untighten,
Hmm.
if only because it feels better after you've smashed it,
Yeah.
only to realize that a few hours later, the pain might come back even worse because now you've probably put in some inflammation into that tissue by
Hmm.
having smashed it in the first place. So again, I mean, we can go on that topic forever, but I think maybe we should pivot and talk about your mechanical transduction concept, back
Mm.
to the assessment. So let's get back
Yeah.
to, so that's from a manual therapy standpoint, the way we see it.
I
And
wanted to add one quick thing before we
yeah,
pivot.
absolutely.
Sorry to jump in. So
Yeah.
just for people that may not, people that are listening in the system that followed all of that, for anybody that might not have, really what you're saying, I think, and you said it without saying it, is as soon as you put your hands into tissue, now you're starting to access the nuances of the internal environment muscularly, connective tissue wise, and you're searching for very specific findings. That's why that haptic feedback or that ability to sense again is a trainable skill. And there's a lot more nuances to it than, let's say, an assessment where, your serratus isn't firing. It's like
Mhm.
it's a very linear, that would be a really simple solution if only I could get somebody to explain to me in a scientific way what that means. Because I never know when clients come to me and they say, "Oh, they said my psoas isn't firing." I just tell them, "I don't know what that means. I'm sorry." And then we
Of
have
course,
a
but
conversation.
you do know what it means. You know what
Of
it means.
course.
It means that the person who's telling them that has the assumption
Yeah,
that the nervous system is to blame for every problem that you will ever encounter.
sure.
It's the same concept of you're on Instagram and someone's going to tell you the 5 best exercises to unlock your hips.
Right,
Well, first off, your hips don't lock in such a way that there's a key that you
right,
can readily unlock them.
right.
Let me go back.
But it sounds really
There
appealing.
is such
Yeah,
key. You can
yeah,
probably do something immediately, which
yeah.
will make you feel like your hips are unlocked.
Right.
Okay. But that's because the nervous system it's just responding. Like it doesn't know what it's doing. It's just
Hmm.
responding to things, right? It's
Hmm.
so when you do something, you might get a response from the nervous system that allows, the pain might come down, or oh, I didn't have that range. Oh, now I have the range, right?
Hmm.
But that's a temporary finding because the nervous system can alter how it functions, but only in time based on the changes that are occurring with the relevant anatomy as well. So, in other words, when anatomy changes, it changes neural function. When neural function changes, it changes anatomy. But you
Hmm.
can't change neural function permanently if there's an anatomical reason why the nervous system wasn't functioning properly to begin with.
Right, right.
So you can't unlock your mobility potential. You have to train
Right.
mobility in order to create potential. in the anatomy that you're trying to use.
Because there's always a bottom-up constraint.
100%. There's
Meaning, in layman's terms, that your biological tissue
Mhm.
is a constraint to whatever, and I shouldn't say whatever sort of neurological output you want to create, because obviously you can compensate,
Mhm.
but to unlock hidden potential, if you think about these findings that we're talking about, sometimes I relate them to clients like lanes on a freeway, right? And
Mhm.
you're trying to maximize traffic. And that's what we can think of as poor quality tissue. We want to maximize traffic so that we have lots of different ways that we can absorb force, manage force, discharge force. The more constraints we have on those freeways, the less movement options we're going to have, the less tissue options we're going to have. So back to this, unlocking your hips. If you can't, you're not going to access more internal capacities by doing a number of external movement patterns, meaning I'm gonna, squat like this, or I'm gonna foam roll like that.
Mhm.
That's not that's not gonna challenge the default state of that biological tissue, which, to quote Dr. Shivers, is the peripheral feedback. So in terms of how you learn and how you navigate the world, that peripheral feedback comes from biological tissue. So if that tissue is not good quality, that peripheral feedback can't be good quality, which is why you can still try to do lots of different, activation exercises or, flows or movement patterns to try to unlock those hips. But that's not doing anything specific to address the tissue quality, which is involved in feeding back, or that bottom up component of feeding information up to the nervous system. That's not going to clean up those filters. Let's say if those poor quality mounds of tissue, or where tissue is poor quality is a filter, those filters are just going to remain, however you want to imagine it, muddy or dirty, or unable to process good, clean information. You wanted to pivot to was it the Don Ingber?
I did, but
Am I saying
funny,
his name
we're going
correctly?
to keep doing this and we're never going to pivot back. We're just going to keep, but I want to get back to it. Again, I want to make
What I'm
sure
here for.
absolutely certain that people are understanding functional range release technique. It sounds like other techniques of soft tissue therapy by name, but I want to point out the absolute fact that
Yeah.
passive inputs will never lead
Mm.
to lasting active results,
Hmm.
such that a manual therapist, they may think they're doing something with the therapy that they're applying, and they may think that that thing they're doing has a lasting result. But the thing that you're doing with manual therapy is only influencing a future possibility of a
Mm.
lasting result
Hmm.
by starting communication with very specific tissues. And what is communication? Well, force. Force is the language of cells. Movement is what we say. So if you have a pronator teres that you feel an aberrant, it's too hard to supinate. It's just too hard. I had this client the other day where they had this long-standing lateral epicondylosis, and you
Mm.
would say, well, lateral epicondylosis, why would you think supinating? Like you should be testing this, you should be palpating. Awesome. That stuff was all there. I'm dealing with that. But the person has a restricted wrist,
Hmm.
very little extension, and very
Hmm.
little pronation. So that means for most of their life, they are not dynamically achieving
Hmm.
long ranges in any direction.
Hmm.
They're also not achieving full elbow range of motion. So those
Hmm.
confinements are going to confine your ability to move and achieve length in tissues. And those tissues, like we said, are going to respond to an
Hmm.
inability to achieve length by changing themselves so that they only achieve the lengths that you use, because ultimately your body is just trying to save energy. It's just, whatever you do with it, it's getting better at whatever it is that you're doing. So the
Yep.
idea that that person couldn't achieve length in their wrist means that that wrist needs something.
Hmm.
Just because the boo-boo is here, that elbow and that wrist need something in
Hmm.
order to allow them to normalize in time, right? But again, I can't do that in one session. I can start the process of putting
Right.
specific forces into the pronator teres in a very specific direction,
Hmm.
but I also have to back that external input up with internal training. And that's why functional range release change is different, because you can think of functional range release as manual training. It's just
Right.
the first step in getting that tissue to change in time with repeated force inputs. It's not, I am not rubbing away adhesions. We don't find pain and then get rid of it. We're not unlocking the magic of the nervous system. None of those things are being done in FR. And I want to stress that. Maybe now, though, we can pivot back to that assessment. So let's assume
Yeah.
maybe
Yeah.
that we have a person, and it's not a manual case, it's a training case. Okay, so the person, maybe they don't have that much pain. Maybe they have no idea where their restrictions lie in their body. They have no problems, but they come in and they want you to program them with exercises. Well, here's the problem. When you go to a gym, it doesn't matter the gym. I use the example of a kettlebell gym, like a
Hmm.
guy who loves
Hmm.
kettlebells for whatever reason. When you go to that gym, no matter what problem you have, that person's likely going to hand you a kettlebell and they're going to tell you I want you to swing that kettlebell.
Hmm.
And that person, that trainer, probably has a lot of preconceived notions as to what exercises are good. Like what's good quality exercise for whatever. That's a
Hmm.
really good exercise for this function. This is a really good exercise for low back problems because I used to have a low back problem, but then I did this exercise and now I don't have a low back problem. Well, again, most people they're arbitrarily deciding on what movements are good and what movements are bad, and then they're applying those concepts to a completely different human system that
Right.
arguably they've never met, right?
Right.
So, you maybe the person has an assessment where they let me see you squat, or your knee comes in. Okay, let's bend your knees so that you can work your knee out.
Hmm. Hmm.
Let me see you get under the bar, see if you can get to a rack position. Oh, you can't. Your wrist doesn't rack. Okay, just go into that position and just force your elbows up as hard as you can until that. So assessment, finding, and then people do whatever it is they do. But I think people are missing
Hmm.
what you actually want to find with an
Hmm.
assessment. What do
Hmm.
you want? What information would be most valuable to you as a strength and conditioning coach
Right.
to decide what exercises would be suitable for that system? Well, you have to map
Right.
the system three-dimensionally.
Hmm.
And you have to map the system three-dimensionally from both an external perspective
Hmm.
to know what they're capable of, but also from an internal perspective so that the actual client feels what they are and are not capable of.
Right.
When you have map them three-dimensionally from an external visual perspective and internally by explaining to them what they should be able to do. What we're doing here is we're creating this intersubjective reality between client and practitioner, where now we have a common goal as to how
Hmm.
to proceed.
Hmm.
So functional range assessment does just that. We are
Hmm.
trying to map the system three-dimensionally, internally and externally. Internally, from the assignment of controlled articular rotations. Talk about a tangent. We can go on forever on controlled articular rotations, but let's look at
Yeah.
it simply from an assessment standpoint. A controlled articular rotation is saying, I want you to show me what workspace I have available to work with regards to exercise prescription in your
Hmm.
shoulder. So I want you to show me your shoulder's workspace.
Hmm.
What is a workspace? A workspace is, if I'm standing here, my shoulder's workspace is all of the areas in three-dimensional space that I can access in order to apply or funnel force through in order to create work, which is to input force through a displacement. That's pretty much all it is. So when I
Hmm.
ask you to do cars, the reason why a car, you know this, but I'm talking to our people listening, the reason why a shoulder car looks exactly like a shoulder car looks, right? And I say this because people, oh yeah, I do circles, I get up in the morning and I do this.
Right.
No, a car is not just a circle, it's not just a basic circle exercise. It's telling you, I want you to move at the outer limit of your articular workspace. So everything is done to the most adduction you can achieve, most
Hmm.
flexion you can achieve, internal rotation, extension. I want to
Hmm.
look at that and I want to look at what you have, where you have capabilities to move into. I use the
Hmm.
exact same example almost every seminar and almost every podcast. If I tell you to bring your arm up, or if you're doing the cars and you start to
Right.
move into flexion, I should see the flexion happening in your glenohumeral joint. Maybe your scapula, of course, will tilt back a bit, but what
Sure.
I shouldn't see is a hyperextension at your lumbar spine when
Right.
you're only halfway through the motion because you lack the physical capabilities to do this. Therefore,
Yeah.
you're putting the onus elsewhere. People often look up or they'll do whatever they can to try to give you what you want. But from an external perspective, if you watch enough people doing cars,
Hmm. Hmm.
you begin to see
Oh
what
yeah.
body it's actually becomes very easy with a little bit of guidance. You learn the car, things get pointed out for you at the courses, and then as I see people coming back to course year after year, they get so much better to the extent that a lot of people start to do what they used to accuse me of, which is what I can watch someone do cars and I could almost give you a history of where your
Right.
problems are. And it's not
Right.
because it's because I'm breaking down the system's capacities and then
Right.
you build them back up and you go, you probably have back pain because you're using your back as a shoulder. Like
Right.
these things
Right.
are okay. So that's
It's very
excellent.
straightforward.
Now
Yeah.
I've watched, I've done every joint, right?
Hmm.
I've multiple views, videotape, whatever you need to do. That's
Yeah.
extra. That's sorry. That gives me an external perspective, but it also
Hmm.
allows the person to have an internal perspective as to what they can do.
Yes.
Because when you
Yeah.
point that out and they go, yeah, that's not right. I can't,
Right.
my arm doesn't go that way. And then I
Right.
say, well, hold your back straight and now try. And they go, oh, when I do that, I feel a weird pinching back here.
Yeah.
Yeah. And then you point out, you say, okay, so because you can't lift your arm over your head unloaded,
Right.
what I'm for sure not going to do is assign you an overhead loaded exercise.
Right.
Your shoulder clearly is not doing what a normal shoulder should, right?
Hmm. Hmm.
Or there's an area. So now that person that has that problem, I'll then go check internal or external rotation because that actually you know this, but it's complicated. But when I watch someone do this, there's a lot of different things that allow this. But when I watch someone do this, it's almost purely how much can this bone move in this socket? And when
Right.
I see that problem, and then I go here and I say, let me check what we call your capsular space.
Hmm.
Your capsular space, the space in your joint capsule, is what allows you the ability to linearly move through your workspace. So when I check your capsular space and I see this,
Hmm.
that tells me that your shoulder is not rotating
Right.
within the socket, but the socket is moving simultaneously with the shoulder.
Right.
Now, this is not a shoulder. If I give you a traditional shoulder exercise to do with a shoulder that moves like this,
Right.
then by definition, the execution of that exercise is not a shoulder exercise. It's
Hmm.
a compensation exercise.
Hmm.
It's on physics. So
Yeah.
cars give you that internal perspective. I have a closing angle pain here, and I have this inability. So now we both have this intersubjective reality that you need a shoulder. So
Right.
now you go into functional range conditioning, which is really our answer to, well, how do you get that shoulder?
Yes.
And this is where people get confused again. They think that all training goes
Right.
into that shoulder such that everything else is left on the back burner. And that is
Right.
100% not true.
Right.
Oftentimes, we let people continue with the same exercises they're doing because
Yes.
they're athletes. They have no choice.
Correct.
But
Right.
in addition to those inputs, we are going to take away some of your training volume and we're going
Hmm.
to input that volume into specifically trying to improve the capacity and qualities of that shoulder.
Hmm. Hmm.
Right?
I wanted to jump in just to add to the cars discussion because I think in layman's terms too, for people that are either unfamiliar or maybe they've heard of cars before, and for even providers that are familiar with them, this happens all the time where that moment that you're discussing let's say the client's got a TL junction compensation when they move their arm overhead. People don't even know their compensations, which I'm never surprised. They're surprised, like clients are surprised because when you explain the task, right?
Mhm.
And I think this is a concept I talk a lot about at the FRC seminar. I know that clients verbally understand what I'm asking them to do. Like, oh yeah, hey, I can do that. Just move my arm. It's like, yeah, of
Mhm.
course. But when you go to do it,
Hmm.
there's a bit of a Dunning-Kruger effect happening here where you're just going to overestimate how well you're doing that. And then when you start to break down those nuances, I always joke with clients like, I promise I'm not making this up, but you're compensating here, 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 here. I can film it for you. We can try to get you to feel it because in a lot of ways, why would you be able to articulate your joints, your shoulder independently? Why would you? Why would a complex nonlinear adaptive system be able to do that if you hadn't practiced or given it a reason to start to funnel that adaptation so that as a default, you have independent articulation from head to toe. The concept is very straightforward in a lot of ways, but for people that have never done them, or even for people that are starting to work with the system and starting to practice their cars, there's there's typically this, and I get this a lot with clients too, like, okay, yeah, yeah, I'm doing them. I got it. I'm doing my cars. And then this requires or usually merits a conversation around, hold on, because now you're starting to treat these like exercises. We
Hmm.
have to talk about that.
Yep.
Because as soon as you default to that, you've taken out the intention,
Hmm.
you've taken out the nuances of these positions, and you've taken out the reality that your nervous system, your body is not going to give you all of the ranges of motion, all of that independent articulation, that control that you want, unless you ask it to do so. So just like anything, maybe some days you'll have some slightly rushed reps, and maybe some other days you'll have better reps. But people who take the course and work with clients, or if you're just doing them for yourself, need to understand that's a huge difference is the intention. And one of the reasons, again, cars are obviously multifactorial in the benefits in terms of maintenance and screening. But one of the really interesting concepts that I think I wrote about this on the blog, my dad's a geophysicist.
Hmm.
So I've learned a lot of cool stuff from him about electromagnetism. And he always has this example, and this relates back to cars, of like a big pile of jelly or jello. And so if you think about anatomy in this way, if you shake that pile of jello really fast, you're going to typically start to just get the movement happening at the very top of that pile of jello. So if you move really fast, we
Hmm.
talk about this a lot more at ISM, you're going to preferentially, again, preferentially, you're going to load muscular tissue. Okay. But with cars, if you actually do them slow and intentionally, back to that pile of jello, if I start to move that and try to jostle it a little bit slower, we'll actually collect the base as well. So it's not just the top jiggling.
Hmm. Hmm.
Again, it's a very simple analogy, but in electromagnetics, this is exactly why they use uh, low frequency to penetrate. So, and through the Earth signaling, where they try to map out, if you think about the Earth and all the complex layers, like, I mean, compared to anatomy, it's massive. It's very, very hard to see and study all of the data and all of the different type of soil and rock and different electromagnetic properties and such. So they have to use low frequencies to actually try to penetrate because there's less scatter. Higher frequencies,
More
the
scatter.
waves actually scatter in the soil and the rocks, et cetera, and the things that they run into.
Hmm.
So in a lot of ways, how FRS uses force is in a much more specific way because as we talk about too, and this comes right out of physics, force has magnitude and direction. It's a vector quantity. So if your only concept of force is exercises, that's a
Hmm.
very limited scope. It's not wrong. It's just, again, it's a limited perspective on what force actually is and how we can speak to these structures in very specific ways, which is one of the things back to cars that controlled articular rotations account for because of exactly how we teach them at the seminar, at FRC, at all the courses. We're very, very specific. I mean, day one of FRC, it's 8 hours of cars. So we're talking about exactly why you're doing this, what you're doing, and then going through all of the musculoskeletal benefits. One of which, again, is back to that pile of jello. We're really trying to collect all of the anatomy without getting into the specifics that belong to an articulation. at the deepest level all the way to the superficial level. That's only possible if you keep in mind the parameters that we've organized and specified for executing this practice, not these
Mhm.
exercises.
Yep, that's a very, very good way to put it. Because it's right. You can do a lot of exercises and never actually stress the tissue that you're actually relying on. Like you see this a lot.
Yeah.
Lateral raises in the gym is always a funny one to me, where you have that, people are doing lateral raises, so you have that initial when they kind of
Right.
throw their arms up and then they let them come down.
Yeah.
I mean, you can arguably complete an entire set with never really activating a deltoid in the least bit just by
Yeah.
swinging. And that's the difference between doing an exercise or intentfully trying to alter a tissue using force inputs,
Yeah.
which is exactly what you're saying. And
Did my rant make sense with the
100%,
all the yeah, the
100%. It's
physics and
the,
such?
the
Yeah.
scatter thing was a great example. It reminds me, for example, if you as you do, but if you deal with very, very high level athletes, what athletes are very good at doing is compensating for problems.
Yeah.
So there's this, they might squat and their knee doesn't come in because they have a way to compensate for it that you maybe can't see. But when
Hmm.
you break down the tissues one by one, those compensations start to go away, and then you're left with what can the anatomy do and what can't it do, which brings us back to that FRA, which again, I want to also point out that it's not only cars. And then we have a
Of
whole
course.
other
Of course.
aspect of this assessment, um, which is active to passive ratios. So I think it's probably an important task for us to kind of explain what
Yeah.
we mean by active to passive ratios and why those are important to begin with.
It's kind of a conversation about range of motion, right?
Mm.
I think you mentioned it earlier, passive inputs and active inputs.
Mhm.
Range of motion is not, and I think you and Chivers actually did a podcast a while ago where you talked about this, and I think it's still not well understood, particularly by folks outside the system. But range of motion, to simplify it, I don't want to oversimplify it, but it's going to have passive qualities to it, and it's going to have active qualities to it. And those passive and active qualities have a lot to do with the behaviors of muscle and connective tissue. So how you discern and how you assess passive versus active, if you think about any uh, sport or lift that's obviously going to be an active movement pattern, there's a prerequisite to that, which is passive. You're not going to suddenly move into an active range of motion that you didn't have passively. It's physiologically impossible.
Mhm.
And so understanding like what a client needs to do and understanding why range of motion is often sort of bastardized to just stretching. If you
Mhm.
just stretch, and this is not at all taking away from stretching, because stretching is, you have a whole lecture on stretch physiology and how important that is. But there's a lot more nuance to it than just, if you have a range of motion problem, you just have to stretch more. And by the way, the stretching is also often, I just thought of this, restricted to movement patterns,
Mhm. Yes, it
meaning
is.
meaning
Yep.
right, if you have a range of motion problem, just get into put your arm in a band over a pull-up bar, and just stretch this stuff,
Mhm.
right? Which is, again, it's not taking an internal perspective. And those of you that are taking the course or about to take a course or have taken a course with us before, if I do this overhead stretch, the prerequisite to that would be that I've cleared rotation. So it's, again, you're putting kind of a paint on the wall and seeing what sticks, right? I'm not saying that might not help, but if you have a rotational limitation because of how we explain and teach the shoulder, you need to address that first before you start to address linear capacity. So stretching, it has a lot of benefit if you do it in an intentional way where you're actually trying to, A, if stretching is the solution that needs to be implemented, but B, if you're doing it with consideration to what level of tissue am I stretching? Am I trying to stretch a capsule here? What
Mhm.
direction? Why would I be there versus you? What do you need to do with your hip compared to me? Versus here's a PDF with 10 stretches that you can do for your your shoulder problem. And by the way, the last 100 patients that came in here are given the same PDF, but they all have different shoulders.
So much. There's so much. Listen. So going back to this car problem, if you don't know what a piston does, then you don't know when a piston is not doing what it's supposed to do. You just know
Right.
that it's just that the system is not outputting what you want. When you have a tight hamstring, you don't know why the hamstring's tight. You're seeing this finding that the hamstring doesn't achieve length, and therefore you're putting length into the hamstring. And you're doing that not because you're wrong, and maybe you're
Right.
right, and that's the problem. But the
Sure.
big problem is the n=1 problem, where everyone seems to have this concept that because it worked for me in that particular time, that's just what you got to do. I have the hamstring stretch. I had a hamstring problem. I
Right.
did the stretch in this particular way.
Right.
You have a hamstring problem. Do the
Right.
stretch in this particular way.
Hmm.
9 times out of 10, that gym owner finds people get better with that. But that one time they don't, and that person leaves and goes
Right.
elsewhere, you're not really tracking. I always tell people that it's like when you believe in your own, what you're doing, right?
Hmm.
Are
Hmm.
you tracking when what you're doing doesn't work?
Right.
Are you, if you're a practitioner, a chiropractor, I help a lot of people. Okay, well, how many people haven't you helped? So in other words, when you're doing
Yeah.
that technique that you do, that you always do the same technique,
Right.
if I ask you for stories, you're going to give me stories about how it worked. But do you
Right.
track how many people came to see you once, received
Right.
that treatment, and never came back? Well, no, I don't track that. Well, then how do you know that you're helping more people that you're hurting? Right? And that's this n=1. And that's why, and we have to think about that too. That's
Of
why
course.
we're bringing this back to first principles research,
Right.
and we're applying first principle concepts to reverse engineer this
Hmm.
problem that is a first principles problem, right?
Hmm.
We have to, that's, anyway, so I don't know if that was just a
No,
pass
no.
or if that
Yeah.
was akin to what you were saying, but getting back to this range of motion thing. Yeah. So there are nuances to ranges of motion, and knowing them is going to be the difference for that 1 out of 10 that
Right.
it didn't work for, right?
Right.
It's higher than that, by the way. But that person is going to need something more. Another good example that I want to use, I use this example at the course a lot, is ankle range of motion.
Hmm. Hmm.
So countless times you go to a thing, oh yeah, my ankles, I don't have a lot of dorsiflexion, and they look, oh, I wish I had that much dorsiflexion. I see that person, and I see them 3 years later. How's that dorsiflexion? Oh, it's still restricted.
Right.
What do? I do this stretch for it. Then they go
Hmm.
against the wall. They put their hands against the wall in the exact same way. Their
Hmm.
shoe is on. They go into dorsiflexion, and then they stretch.
Hmm.
3 years later, I see them again. How's that ankle? Still restricted. Show me what you're doing. Same position on the wall, same pair of shoes,
Right.
same stretch. Okay, so the stretch,
Right.
right, the patterned stretch that you're molding yourself into because someone said this is a great stretch for your ankle, that you're doing may not be affecting your ankle and your
Hmm.
triceps surae group, your gastroc, in the same way
Hmm.
that another person doing it. For example, if you have a lack of subtalar tilt,
Hmm.
if your calcaneus is locked in place so you can't tilt, so every time you move to stretch, the way that your joints allow movement to occur, you're going to stretch into the exact same line almost every single time. You keep stretching into the same line, you might improve, but eventually, all of the other tissues that have not felt that length are going to start to become walled off because all you're doing is stretching into the same line. Now,
Hmm.
you can stretch into that same line all you want. Eventually, people start to say, you know what, I'm stretching, same stretch, but now instead of feeling a pull on the back gastroc, I'm feeling a pinch on the anterior aspect of my ankle. So what'd you do? I did more stretching. Or
Right.
someone said, get in a position and now put a kettlebell on your knee so that you can force it even further.
Right.
The problem is that you're stretching the same line of tissue. This gets back to what you said before. A muscle is not a muscle. A
Right.
muscle is thousands of individual fibers that are bound together into a word noise that we call the gastroc.
Right.
But if you take that talus and that subtalar joint and you allow it to tilt, and
Mm-hmm.
now when you stretch, you do the stretch sometimes barefoot,
Mm-hmm.
sometimes with your foot out a little bit, sometimes with your foot in a little bit, sometimes with your shoe on so that you have some supination, sometimes not. When you're doing multiple stretches in this way, now you will start to divide where the stretch goes, and you'll
Right.
find that that achievement of range isn't dependent on did you do that particular stretch. It's did
Right.
you give the information to the tissue that was necessary in order to allow stretching to actually do its job.
Right.
It's
This also brings up how much stretching is necessary, which is, again, when you're building range of motion, how much passive range do you need? And that's
Mhm,
obviously going to vary client to client. But if, outside of the system, if the understanding is just more stretching is better, it's the same problem that we have discussions with S&C coaches and strength athletes about, which is how much strength do you need? Because the range of motion is the same thing. You need what you need plus a buffer. So if all you do is passive stretching, you may actually have, obviously, you were talking about some more nuanced biomechanics, right? With the ankle uh,
mhm,
uh, tilt being a prerequisite to linear motion being dorsiflexion. But in the situation where somebody, let's say, actually had the passive range that they needed, but they just continue to do more passive stretching, you're missing opportunities to backfill that passive range now with active range of motion, which is training. Active range of motion is, as you've outlined it in the system, there are steps that increase in neurological complexity. So when you ask somebody, especially like a client or somebody that hasn't actually trained to close that gap, they quickly realize that this is not a warm up. If
mhm,
you want this range of motion, you often make this joke, you're going to beg me for deadlifts because closing that gap between your active range of motion and your passive range of motion is training because your nervous system and that biology is not going to give you that unless you specifically work for it. And and that's why, again, if you have the passive prerequisites, then your time is spent doing active training. And if you lose, let's say, passive range, and you need to restore that, then maybe you're going through another block of doing passive stretching again. But it's always backfilled because, by the way, the problem in a lot of, from a myofascial force transmission standpoint, again, a lot of sports, a lot of lifts, life in general, usually comes when we try to do something active. I'm trying
mhm,
to use an active range of motion. Not always, right? I'm trying to go through an active range of motion, and now it's hurting. I don't have, like, something up here doesn't feel good,
mhm.
right? I've been stretching it, but man, when I go to like reach overhead, I'm getting this problem, getting this pinching, right?
Yep.
So that's so active range of motion is a whole other conversation, but this idea that range of motion is,
We haven't even got into
yeah,
active range of motion with regards to preventing damage when using that range of motion,
yeah,
which is another topic that we can briefly talk about. We talked about before, but like you said, you don't have a range of motion, and now all of a sudden you're passively doing something that may grant you access to that range of motion. But
right.
based on what I said earlier, that range of motion is new to you, which means it
Yeah.
has zero experience
Hmm.
functioning. So, you have your passive range of motion to here. We
Right.
stretch you for however passively for months, and now you can come up here. Well, okay, so now this gap here, there's tissue within that gap that's now accessed that hasn't had force information for a long time,
Yeah.
right? And also, because it hasn't had force information given to it,
Yeah.
because it can't move, the nervous system hasn't received feedback from it for a long time. So
Yep.
now there's this lack of neurological communication, but
Hmm.
in a range of motion which you didn't not have before. Now, on an Instagram before and after, that looks great.
Hmm.
But
Hmm.
in reality, when you're in this new position and now force is being put against you in that position,
Hmm.
your inability to create strength
Right.
in that range is going to ultimately lead to whatever force going in, overcoming your ability to absorb the force, which leads to injury. That's why strength is what, there's another funny thing. Strength is what prevents injuries, right? But just being generically strong is not injury proof enough for the problem or for the injury that you just sustained. In other words, you can be a powerlifter, bodybuilder, strongest guy in the world. That
Yeah.
doesn't mean that you're less prone to injury. What we're
Yeah.
saying is that individual tissues, when
Right.
put under stress, can only absorb so much force.
Yep.
When that individual tissue is absorbing an amount of force which is in excess to what it can absorb, the
Right.
tissue yields under the force and you have an injury. So the idea that active ratios and active to passive ratios are unconsequential is false. If you have active range of motion, a passive range of motion that you can do the split, but an active range of motion that you can lift your leg to 90, you have 90 degrees of motion, which when challenged will fail the force absorption challenge quite easily because it hasn't had experiencing absorbing force. It hasn't been trained to absorb force in so long, and your body is only prepared for what it trains for.
Yeah. It's you're making me think of just also because we've been doing this as an example position. I have a young baseball athlete that I've been working with, and he was a perfect example of somebody who had a ton of so a couple different talking points here. One is the amount of work required to build active range of motion. Um, but in his case specifically, had all the passive prerequisites.
Mhm.
So that wasn't his problem. So that's not where we spent time. That would
So
be,
you said he's a pitcher.
yeah, yeah.
I'm
He's a serious
assuming
pitcher.
what you
Yeah,
mean by the range of motion he requires is that ridiculous amount of external glenohumeral rotation that only pitchers can achieve,
insane. Yeah,
which
yeah,
is garnered
yeah.
passively over time
Correct.
because of the mechanics of pitching, which forces you to quickly whip back your arm over and
Yep.
over and over again,
Yeah.
such that that quick whip back will eventually start to creep you more and more range of motion.
You get that plastic deformation over time. Exactly. Yeah.
To the extent that even in pitchers who have been pitching for young, even the humerus itself will begin to contort
Yeah.
because of that frequent passive range. But I don't want to take your thing, but I'm assuming that your picture, when challenged actively
Yeah.
to come out of that range of motion, had an almost lack,
Disaster. Yeah.
no ability to generate force.
Right. But what's interesting for so 100%. What's interesting with him though, he recognized at the simplest of levels why that's a problem. Because that's always how I start these conversations with these athletes. It's really simple. I tell them let's not get complicated. Just think about what I'm asking you to do, right? And again, for people that are listening, we're talking now about active range of motion, using that range of motion to put it simply by putting some force into that tissue. Just keep it really simple. And you have an inability to do that. But your sport is requiring you to get into this position specifically and generate a large magnitude of force repeatedly,
Mhm.
right? And so, without getting into too many of the details, the history of injuries and this injury specifically that he had was in a lot of so initially it was very discouraging because of how young he is. He again, a lot of young athletes don't think that they follow the same rules of biology that you and I do, but again, what you don't train is a liability in the sense that you want to have that's your insurance, right? We always talk about this with athletes and clients. Like we can't guarantee that there's no such thing as injury prevention, okay? But you're doing something abnormal with this shoulder for your sport and at a high level. So the best we can do is try to mitigate the cost of you repeatedly throwing 90-mile-an-hour fastballs and try to give the tissue a buffer against that. And active range of motion or active training, closing that active to passive gap involves putting tissue specific forces that match, right, or that are going to create a buffer against the force profile of that sport. Meaning that you could say, well, why don't you have them do bench press And we'd have to get into a conversation about why bench press is very different than joint specific training. Bench press uses a shoulder joint, but bench press isn't going to specifically train his shoulder joint at length, even if it's
Mhm.
full range of motion. It's different than full range of motion, glenohumeral joint, and external rotation, adduction or abduction, right? So closing that gap for him has been really interesting to see also because this athlete is so young how fast they can adapt. And again, it's not fast, but it's so much faster. It's really interesting to observe compared to a lot of my, let's say, older clients that I work with in their 50s and their 60s, which always brings me back to like a guy like him, for example, he's really setting himself up for success because that
Mhm.
adaptive currency is so much richer at his age. My older clients, they all say the same thing. I wish I started this 10 years ago. But it doesn't change that we're still trying to close those gaps, those active to passive gaps, give them the ranges of motion back that they want and need, and understanding how much work is involved to close that gap. Especially when you want like you want a long-term adaptation, you know, that has to be so for example, when we were working together off season, that was his priority. Now he's approaching in season. So now it's just going to be trying to maintain and basically do damage control of what the season is going to cost them.
I can hear, I can see, or I can feel people who might understand pitching mechanics, and they need more information, or they're going to think we're going crazy.
Yeah, yeah,
I want to just,
totally fair.
when you're pitching, okay, it's a matter of using your arm as a passive whip, whereby when your arm goes back, you're supposed to be generating, or you're supposed to be creating potential energy
Hmm.
that can then be translated into kinetic energy, bringing the ball forward at a particular velocity before you let go of that ball and the velocity continues. So when we're talking about training back here, I'm not saying that he needs the ability to throw actively from here necessarily,
Right.
but we're talking about training both the red tissue or the muscles, as
Yep.
well as the connective tissue to
Right.
increase the ability to absorb force.
Right.
So you increase the ability to absorb force, yeah, you decrease the chance of injury, but what you also do
Right.
is you also generate the ability to store more potential energy in the connective tissues. And the more you store,
Right.
when your muscles contract and they shorten, and then that shortening gets propagated to the connective tissue, and that's how your arm goes forward, the amount of force that that white connective tissue can absorb
Hmm.
is going to play a big role as to how fast the muscles can pull on that connective tissue.
Hmm.
So it's not just a matter of doing, just do an exercise back here. We have to be very specific, and we do this in the system. First, we're going to lay down the foundation of white connective tissue to absorb force.
Hmm.
Then we're going to go back in and increase the capacity of the muscle to propagate force into that connective tissue at the exact speed that is required in order to
Right.
perform that exercise, because muscles are simply a speed conductor. They decide how fast
Right.
to execute force into connective tissue. So I just
Right.
wanted to point that out just so that we're not oversimplifying for the people who are
Of course,
more information there.
it may not be the best analogy, but I some like with him because I always try to make things as simple as I can for clients. I was trying to relay his pitching arm like a spring, right? And so that spring has a certain, if you think about a physical spring, it's going to have a certain amount of density and thickness to it. So what I was telling him is if he thinks about it as a spring, if you're starting to load, right, or load up for that pitch, and as you're loading up, the spring, let's just say it breaks or there's a crack in it, which is what was happening, right? And then the ouchie happens, right? It hurts here. This doesn't feel good here. I don't feel like going back the other way now and completing my throw. So recoiling out of that. What I was trying to explain to him is we can think about training that load up process to make that spring more robust and dense as you load up for that pitch so that when you recoil out of there, you have more confidence because what was happening is he didn't have the confidence to really put some drive into it, which goes back to, and this is kind of getting into a little bit of some of the ISM concepts that we teach, but you can be an athlete that has, I mean, I've met a lot of athletes like this I know you have as well. All of our instructors have. They can drive. You tell them
Mhm.
to drive, you tell them to do their sport, they can drive. That's not the problem. The problem is the biology, the state of the biology is not keeping up with the drive. There's a high cost associated, which is always why, again, when we look at performance, that sometimes is an issue where an athlete can't drive appropriately. But in the cases where that's not an issue, that's one thing that we can put a check mark next to. Okay, you can drive. Great. The problem isn't that you're not able to drive. The problem is that the biology is falling apart or there's a high cost associated. We have a history of injury, we have recurring injuries. You don't have the same amount of confidence. And athletes can speak to this in their own way because they can feel, especially athletes that repeat a sport or movement pattern, a pitch, running, etc. They can feel what's happening because they repeat these ranges of motion all the time. So it's really easy for them to give the feedback and say, like, yeah, I don't feel good back here. I don't want to be in this position, but this position I have to be in for my sport.
I often say with athletes, I mean, if an organization sends me their top athlete, my job is to just get their body out of the way, because the reason they're the top athlete is because their nervous system has the capacity to drive, like you're saying.
Yeah,
LeBron has
they're the
the
best.
he knows. I mean, if LeBron comes to you and says, "I need to get better at basketball," or "I need to get," what do you do with him? Do you just give him more squats? Well, let's make you stronger. Well, there's an
Right,
upper limit to that. Like, what can
right,
you do is you can look at LeBron, the body, and then eliminate restrictions that don't allow LeBron's brain to send signal to get the exact result they want out of the biology. And then what you can do subsequent to that, which is it's going to lead us nicely into kind of the other system that we haven't discussed yet, or part of the system, which is the internal strength model.
hmm,
You can now start to specifically look at capacities and anatomy, and you can begin to specifically build up anatomy
hmm,
such that the system has more access to more tissue to do more with, which is which is brings us to the FRS internal strength model. Another example is you have a distance runner, which we always talk about. If you have the best distance runner in the world, and I say make him better,
right,
what are you going to do? Tell him to run more? Well,
right,
I mean, he's the best in the world. I mean, so in
right,
other words, he has probably or she has sucked out as much ability out of her system
right,
that is possible.
right,
That's why she's the best. So
right,
her endurance, she can pull out so much endurance from the tissues that are involved in running that she
hmm,
can do it better than anybody else. So
hmm,
what do you do with that person?
hmm,
This goes back to there's general advice that most people can take, and then there's specific advice,
right,
which is why we get accused of being too complicated. But that
right,
person needs specific advice. Something I can do for that person is I can specifically select areas of the body that are utilized through endurance over a long period of time to run with, and I
hmm,
can improve the qualities of those individual tissues in a specific way such that
hmm,
I'm giving them more access to more tissue that they can then pull more endurance out of. An
right,
example, you give me an endurance runner and you say make them better. One of the things I might do is train with what we call an input seven, which is a slow twitch to failure. Train for example, slow twitch fibers of the intrinsic foot
right,
in a way to literally hypertrophy the
right,
slow twitch fibers of the intrinsic foot
right,
such that the endurance system has more slow twitch fibers to call upon while running.
right, right.
But that is not going to occur when you say, well, how do I do that? Well, do towel crunches. How many? I don't know, just do like 3 sets of 10. Why 3 sets of 10? Because those are just the mouth noises that people give to try to simplify exercises for the masses. But we know through physiology that in order to access slow twitch fibers and fatigue them such to tell the body, I need more of this particular type of fiber, there are
Mhm.
very specific loading parameters
Right.
under tensions that must be um, that must be followed,
Yeah.
pulled out of the scientific literature, by the way, not like we invented it.
Yeah.
There is first principles literature for this that will make it so that you can specifically get the capacity that you need. You know, the hips, for example, you take a runner and you take let's take their glutes, their glute min, glute med. When you're running, the people, it's very important to make those strong. What do you
Right.
mean by strong?
Right.
Strong how? Strong fast? They need to
Right.
be able to contract fast with a lot of force, or do they need
Right.
to be strong in the ability to absorb forces?
Right.
What do you mean? Well,
I'm gonna squat.
let's just squat. Like I have an idea, squat more. Well, no.
Right.
When you run, every time you step down, there is a little bit of lateral pelvic sway that occurs as the
Mhm.
foot goes down. Your glutes have to eccentrically contract
Mhm.
to stiffen the pelvis such that you don't have too much lateral sway. So in
Right.
other words, it's a terrible example, but when you're running, every
Yeah.
time
Yeah.
you step down, your hip is going to go out. So we
Right.
don't want people running like this. Please don't take this and put it on Instagram. We don't want people running like that because that's a lot of lateral movements. Whereas in running, we want to confine the energy into the sagittal plane. We want you to push into the floor and move forward. So we want to lessen the amount of lateral pelvic sway by
Right.
increasing the ability to stiffen that pelvis on impact, which means that we want to preferentially increase the connective tissue density of that tissue on the outsides of your pelvis, which means that we have to train for connective tissue in a way to increase connective tissue load bearing capacity. And that will entail stiffen up that pelvis and we lose less lateral pelvic sway. Or we have less, so it's more sagittal, if that makes sense. So in the ISM, to kind of generalize what that part of the system is, that part of the system is just, FRC, FRA, FR. We're getting the system, we're trying to make the system do what it needs to do, give it the prerequisites it needs in order to achieve, not just bring back to human, but bring back to the level of prerequisites that person needs to manage their life. If they're a high level athlete, it's beyond just bringing them back to normal human levels. But once we have their system in a state where the prerequisites are there, it's functioning well, it's able to execute the speeds it needs for its sport. Now we can say, okay, how do we squeeze more juice out of that lemon? What do
Mhm.
we do to improve that
Mhm.
person's performance?
Mhm.
Where the standard model fails here is that the answer usually is practice with the stuff you have in a different way. Practice at different speeds, practice the movement pattern as it is, get better at that movement pattern, get more honed, be more efficient at the movement pattern. Great. Let's say we've done that.
Right.
Now where do you go? Well, now you need to change the qualities of the anatomy because you're asking for a higher degree of output.
Mhm.
That is not going to come by just, oh, try this exercise now. Oh, I bench, you do 3 by 10, do 3 by 12. Oh, no, I do 3 by 5. Increase the, you're doing the same thing over and over again. You have to be specific
Right.
in how you're changing the capacities and what anatomy and what exercise will specifically challenge the anatomy to get the result that I need. And that cannot occur with patterned exercises. Not to
Yeah.
say
Of
that not to say that we don't prescribe patterned exercises. Of course,
course.
we prescribe patterned exercises.
Of
Of
course.
course, we're deadlifting and overhead pressing when necessary and squatting
Sure.
and all of these things. But the belief that these named exercises are going to homogeneically improve all tissues in
Right.
in the way you want it to, all of the time, just by having done the exercise, is completely false.
Let's 100%. I want to you're saying something without saying it, and I want to tease it out for people that are listening because I feel like we pick this apart a lot in the ISM, but what you're really talking about is the allocation of volume. And I think it's important to remember the history of where this, what we talk a lot about the volume problem comes from. Because when we talk about the volume problem, we're not saying that there isn't a place to do the volume that you need to do. For example, if your sport is powerlifting. But the volume problem is a problem because powerlifting as a sport, as John Quint talks a lot about, one of the FRS instructors, it's a sport. And so if our standards for lifting came from powerlifting, meaning the volume, and all sports are different, all athletes are different, have different individual capacities, why are we, and we see this all the time when we work with a lot of the staff and athletes that we work with, why is the strength and conditioning, why does it look so similar from a volume standpoint and from a training standpoint in terms of what they're doing? Why does it look so similar for different sports? For example, we talked about baseball and we talked about LeBron James briefly, basketball. So in those sports, do you have to move another person, right? I grapple, so I've been doing jiu-jitsu, wrestling, judo since I was 14. You have to move another body. It's very different. So how I would train a jiu-jitsu athlete, right, it would be very different than how I would train a basketball athlete. But if you look at their strength and conditioning, and again, it's not saying that they won't get some benefit. We're just saying the level of specificity that you could tease out, knowing that adaptive currency, there's only so much of it to go around, depending on how much they're playing their sport, with their in-season, off-season, etc. Why wouldn't you tailor their training to be even more specific so that that specific basketball player that has a left hip that's not going to be the same as his teammate's left hip, like why wouldn't you train that individual based on A, their limitations and capacities, but then also B, based on the sport that they play? Does that athlete actually need to spend more time squatting, let's say, right? There's a place for the squat, but if they've squatted enough, right, and we've gotten, let's say the goal is to increase their absolute strength. Okay, we've hit their absolute strength goal. So now, based on their sport, is the answer just more volume, more strength for an athlete that needs to be mobile, that needs to move, that needs to react, that needs to stress stiffen, that needs to explode? Where's the training specifically for those behaviors that need to happen on the court? Right. And I think that's where the volume problem comes from, is that the standards had a good intention. We,
Mhm.
we we looked at power lifters. We saw all the volume they were doing. We saw them compete, and we went, "Holy shit! These are some of the strongest people on the planet. I want to train like that." But then we
Mhm.
forgot to account for the fact that, well, if that's not your sport,
Yeah.
and your sport is, and again, it could be anything. Maybe you don't have a sport. Maybe you're the person, I just want to play with my kids and go on long hikes and occasionally bike ride. Great, but then keep the goal and train for those things, right? Or if you're an athlete in another sport, let's say you're a jiu-jitsu hobbyist. I recently worked with a jiu-jitsu athlete, and we had this conversation as well in terms of like, what's your sport? Where are your tissue-specific weak points? And how can we basically make you specifically better for your sport based on your weak points, right? More deadlifting is just, it's too general.
I think it's worthwhile. We talked a lot about the system, but I think it's worthwhile to discuss why these things are not considered. And I think the major reason why it's so easy to say, well, LeBron James didn't do that. He didn't do any of that. Like,
Right.
well, he did because, but let's pretend we never
Yeah,
take
yeah.
any great player at whatever, and you go, well, they never trained that way. So why
Sure.
train that way? Again, this n equals one, this lack of understanding as when who makes it to the pros? Is it the best of the best or the best of what's left after people fall off due to preventable tissue related injuries?
Right.
Because I can tell you in my career, which is longer than I want to admit right now,
Mhm.
out loud, I've seen some of the best athletes never reach any of their potential
Mhm.
because of the injury that you never heard about.
Yeah.
And then you say, well, that guy who became the best, he never did any of that. Well, again, that's what we're saying. We're saying that every system is different. And a
Right.
lot of becoming a great athlete is the ability to compensate and deal with tissue injury and problems. We deal
Hmm.
with a lot of fighters, and I don't think people appreciate how well fighters can function with
Yeah.
a horrendously dysfunctional body.
Do you
I
remember that case? I don't want to
Yeah,
name him, but that I sent you? Yeah.
yeah, the case that we were working that we were yeah, we could do it a couple of months ago.
Yeah.
That fighter just I mean, you would never believe. I often tell people, look at retired football players. You would
Yeah.
be surprised at what condition their bodies are in, especially if they were never given joint specific training with the intention of improving longevity, which is something we never even talked about with the training
Mhm.
methods. We went right into, what it does, what you have to do, but not to mention the fact that if you're not training the body for longevity and
Right.
you're also putting sport specific insults into the body over time,
Right.
that body is going to end up brutally broken at the end of that career because you haven't focused on joint health. But that's another topic
Yeah.
altogether.
Yeah.
But I think I was getting at the point where I think that's where people go wrong. Another thing, like you see a video of a fighter, let's say, and he's like, oh, well, this fighter does this particular type of training. And then they, oh my God, that training's amazing. But how long is that fight? Was that guy already a fighter? So he already was incredibly skilled.
Right.
And now he started this new type of training, and now you're seeing him improve. But that didn't build the fighter.
Hmm.
So a lot of fighters, they'll do a lot of plyometrics. Like there's some strength and conditioning coaches for MMA. It's just complete plyometrics all the time. So in other words, their focus is speed, speed and speed alone. Yeah, if you can take a person's body and then you can make them execute things faster, they are going to function better to a point,
Hmm.
but eventually that speed is going to overcome the ability for the connective tissue to absorb the forces that you're making. And now that shoulder blows out. And instead of saying, you know what, maybe instead of only doing plyometrics on season, off season, in camp, out of camp, all the time,
Hmm.
maybe you should have altered your tissue specific training in a way to support the speeds that you're trying to garner from
Hmm.
doing this plyometric type training. But what does the outside world hear? The outside world only hears, oh, that fighter did those drills with that trainer and then won the next fight,
Right. 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 Right.
right?
Totally.
They don't
Totally.
hear that that same fighter that did those same drills that won the next fight lost the next two and then
Right.
had to retire because of a
Right.
labral tear
Right.
that has been bothering them that was irritated by
Right.
increasing the speed execution of the shoulder time and time again
Yeah.
for the purpose of fighting better, but not for the purpose of caring for that shoulder. It's
We
again,
look at the performance. We weigh the performance too high and the outcome. They won the medal. And again, not to take anything away from, they won the title, they had this performance, they broke the
awesome. Yeah,
record. All of
yeah.
that stuff is all it's separate of the longevity conversation. And I think even the framing sometimes of these problems like and I'll speak to jujitsu because I work with a lot of those athletes. The problems even gets framed from a movement standpoint. I can't play this game anymore. I can't move over here, right? A squatter, I can't do this type of squat anymore. It's not the squat that's the problem. It's
Mhm,
your hip or your like it when you break down,
mhm.
right? It's not like, oh, I can't run anymore. It's because running it's not doesn't work for me. It's not the running isn't the problem. I mean, it is the problem, but why it's the problem is because of the internal components that you use to run. So what you're bringing to the table to run with is
Yeah.
not up to snuff to allow you to run. But it's this problem that I feel like has this oversimplification in terms of how it's solved, which is just, well, I just don't run anymore, or I just have a bad back, so I just don't bend over anymore. And
Mhm.
with athletes, especially, and even if you're not an athlete, if you're just Gen Pop, in the interest of longevity, and I mean, I don't mean to take this in too many different directions, but of all the popular discussions right now, we're talking about social media, everything trending. We don't have to name anything, but all of the trends, right? This supplement, this injection, and again, all of these things may have their place. I don't want to get into the weeds, but where's the discussion? Where's the priority
This is,
on specifically training your joints
yeah.
and the time that it takes and the investment that, in our opinion, is very much worthwhile? Because again, who knows what new drug or medication or like who knows? We could have some amazing technology, right? But everything we know from evolutionary biology, everything we understand about these cells, all of the nuances of how force profiles need to be imparted
Mhm.
specifically to these tissues. Where's the conversation around not just maintaining your joints, not just warming up, but actually training to try to mitigate the wear and tear of all the fun things that you want to do, either again as an athlete doing a sport or as Gen Pop.
Yeah. Yeah. I don't want to take too much out of that because I'm doing a podcast with Josh uh,
Oria.
Albert soon on the longevity versus performance discussion because that
Oh, there
really
you go.
does require a lot more conversation. Does an ice bath help you? Well, from what we know, possibly marginally.
Sure.
But you know what does help you?
Yeah.
Moving your joints individually more frequently throughout the day for the rest of your life. I can 100% tell you
Right.
because I know that the way to maintain a joint's health is movement, and there's no other answer. You can inject collagen and glucosamine and whatever vitamins you want into my joints, but if
Right.
my joint is not moving, getting rid of waste products, imbibing new tissue or imbibing new fluid, stimulating all tissues that control that joint to the extent of their range of motion that is possible on a regular basis. That
Mitigating the maturation of fibrosis, right?
that joint cannot maintain health over time. And far too often now, the idea that longevity is so important now and such a buzzword, but how it gets confused with performance is remarkable. Like,
Yeah. Yeah.
and I talked about this the other day in a post that the idea that an athlete is somehow at a higher level of musculoskeletal health is completely ass backwards. Like,
Yeah.
if
Yeah.
anything, the cost of who said this was Mike Ranfone, who was one of our
Mm.
instructors. He said the
Hmm.
cost of high performance is your health.
Well, yeah, that's right. I remember that. I remember that.
Brilliant. I mean,
Yeah.
that is we've dealt with how many athletes now throughout their careers, and
Right.
that is 100% the case. So,
It
you
is
know,
the case. But
it is
that
the case.
cost,
But listen,
yeah.
social media, man, I want longevity, but I want to be functional.
Hmm. Hmm.
Mean functional. Do you want to function as a human or do you want to
Hmm.
function as a hockey player? Because the definition of functional is different, and the
Hmm.
result of being that way functionally is different. Hockey players probably going to have a good amount of arthritic development in those hips. I know it because I've seen it, right? You're training to be a functional human because you want to play with your kids when you're 40 or 50 years old. That's a different thing. Longevity, when you're 80, that 80-year-old is doing Olympic snatches. Good for him.
Right.
That does not mean that Olympic snatches are a longevity exercise that should be blanketly given to
Right.
everyone just for the fact that it's the thing that helped you. It's
Yeah. Yeah. It's
you know
almost back to the overcomplicating, I think, overcomplicating what training and health and longevity should look like. Like it doesn't have to be the volume, right, that you think it needs to be towards exercises. And again, it's not taking away from all the positive benefits of exercise, but because the fact that exercise is not joint specific training,
Mhm.
if there's any argument for where the volume should be spent, especially if you've done zero joint specific training, it's like maybe start there. Uh,
I think
you know?
exercise should be thought of as using the system and improving the system's ability to function as a system.
Yeah,
Training is changing the system
right.
to increase those abilities at a later date.
Yeah,
And exercise and training are not the same thing, and we've said that for quite a long time now. And
Yeah.
again, yeah, that volume problem's a kicker because, you know, when you look at someone and you know, I want to maintain myself in time, where do you look to? People look to athletes, they look to functional training, they look to these, but maybe that's not what we need to do. That's what I've always thought this. Like I I've had a history of a lot of weightlifting, like when I was younger,
Hmm.
considerable amount of powerlifting, considerable amount of Olympic lifting. Uh,
Hmm.
I did some bodybuilding. Like I did a lot of different things for different reasons. But now I don't do those things. Not
Hmm.
because I don't find, like, listen, a snatch is a great exercise when you know what a snatch is for and what you're trying to
Right.
accomplish. If you need it,
Right.
snatch is a terrible exercise for me. I'm not going to garner for what I do with my
Right.
life.
Right.
I
Right.
am not going to garner any benefit from doing snatches.
Right.
If anything, I'm just going to increase my injury risk, and that's not what I'm trying to do
Right.
currently in my
Right.
life. You know what I mean? I need to be functional enough. You know,
Right.
we do jujitsu and kickball and whatever mixed martial arts, and fine. But more importantly, and I also say this at seminars, is no matter, you know, especially when we're talking to the young trainers, no matter how much you think as a 25-year-old trainer that your client has the same goal as you, which
Right.
is to be functional
Right.
or have abs, you really need to reassess what those people, because your goals are not their goals. And I'll tell you something right now, abs are not a measure of human health. The visualization of abdominal
Right.
muscles is not
Right.
is not an outcome measure of human health. I remember many years ago, the Los Angeles Kings had won the Stanley Cup, and they had a picture of them, all of
Hmm.
them, in the locker room. A lot of them had their shirts off. You know what I
Hmm.
didn't see? I didn't see one six pack,
Yeah. Yeah.
any of those people. So not
Hmm.
only are visible abs not a marker of health, visible abs are not even a marker of performance,
Right.
right? But that's the markers that we hear about on social media. And
Right.
that said, 5 best mobility exercises to unlock my hip are the following. And that guy said that when you have any back pain, that foam rolling is the magical cure. And that guy said that no, it's actually acupuncture because that's what I did.
Hmm.
There's a lot of framing problem in the
Yeah.
industry. And again, if we're sounding overconfident, believe you me, this is not coming from a level of overconfidence. It's coming from a lot of years of trying to break these things down into first principles and then applying what we're doing to lay people, injured people, as well as athletes at the highest level, and then monitoring what
Hmm.
results are, follow up FRAs, follow up palpation, follow up assessment, which is something that we always, always, always discuss. I mean, the main conclusion here, which probably should conclude because we can go out for over 2 hours probably,
Yeah. Yeah.
is it, we don't overcomplicate things. The system is complicated all by itself.
Right.
But within the guides of a new system, there are ways to organize the training in very efficient and effective ways. And that's what the functional range system has done, is it simply looked at all areas of managing the human system, the Homo sapien in time, and looked at the literature available for managing those Homo sapiens and
Hmm.
reevaluating that literature from a different lens, just looking at things differently, and then applying that information to a training and management system that is human centric,
Hmm.
not pattern centric, not sports centric, not predetermined movement path centric, but human centric.
Hmm.
Bench press is not for Alex's shoulder.
Right.
Alex uses his shoulder to bench press with, but the bench press is not for your shoulder. The squat is not for your hip. You use your hip to squat. Ergo, the hip, because we
Hmm.
can say the word the hip, it means that is a definition of what a human hip should be able to do for us to
Hmm.
define it as a hip. And if I can't define your hip as a human hip, then giving you an exercise which requires a human hip is more detrimental than beneficial. And it doesn't matter what the exercise is.
The system is as nuanced as it needs to be, but it's not more complicated than it has to be, right? We don't make it more complicated than it needs to be. We're just appreciating the nuances that come from biomechanics and evolutionary biology and basically, I think it's you or Dr. Chivers has a whole lecture in one of the summits on the development of joints from an
Mm.
embryological standpoint, right? Like this is the system is the system because of what the evidence has told us it is.
Yeah. Yeah.
And I think just to circle also back to like the longevity piece as well, back to definitions, right? What is fitness? What does it mean to be in shape? I'm doing snatches because I'm trying to get in shape. You might not need to do snatches to get in shape. What does in shape mean to an athlete versus, you know, a grandma versus, somebody who just wants to play with their kids? I think, health and fitness, there's a dark side to the back to the volume problem, just overdoing more volume. I'm trying to get more health by doing more, but oftentimes taking a step back and looking at, well, what's the state of the system that you're doing all of that volume with? and
Mhm.
and being able to prioritize the things that allow us to move and the things that break down. We talk a lot about where a lot of injuries tend to be in joint and connective tissues. So if that's the case, right, if we see a lot of that, or you and I do, and a lot of our instructors and providers do, if that's where we're seeing a lot of problems, where's the training
Mhm.
to help mitigate that?
Listen, every time we do one of these, I don't know where to end off, but I think that that might be really nice segment to put this to a rest. I will say that we did talk about the volume problem. There is an episode of the Control Yourself podcast. It was with myself, Quint, and Dr. Chivers called the volume problem. So I can point people to there. A lot was talked about on range of motion. There's one episode called the Range of Motion Compendium that I do with Dr. Chivers, that you can go through that rabbit hole even further. But I want to thank you because I think we got a good amount of information. I mean, we can do this, and we have done this for several hours more, and we can get more and more specific. But I think that we've given a good overview, not maybe of every single component in the functional range systems, but an overview as to how we structured the functional range system and how it works in the management of clients based on force transmissions and understanding force transmissions and what they do to tissue over time, et cetera, et cetera. So I hope that people got a lot from this episode. I know I did. It's always good to review the concepts. So thank you very much, Alex. I'm going to have you on sooner again than later.
Thank you, my friend. Appreciate the time.
Okay, very good. We'll see you guys next time.